Well, the next topic of my that I'll be talking on this morning is on the diagnosis and management of the kidney transplant recipient. So as you all know, kidney transplantation is the optimal form of kidney replacement therapy in children, as this results in superior growth, improved neurocognitive development and academic performance, and very importantly, better quality of life and rehabilitation. And for all of us who transplant children, we hope that every child with kidney failure can get a kidney transplant that will last a child's whole life. See, but is this really a dream, you see? So if you look at this large registry data from the US, from the European data, from the Australia, New Zealand data, and from the NHS data in the UK, you can see that in terms of allograft survival for both living and deceased donor, for the first 5 years, it's relatively good, ranging between 80 to 90%. But once you reach 10 years, okay, it drops right down, even for the living donor to about 70%, and for the deceased donor right down to 60%. So why is this so, you see? And when you look at our Singapore data, we see the same phenomenon. For the first 5 years, we have relatively reasonable survival, living donor 92%, deceased donor 78%. But once we reach 10 years, again, it plunges to 80% for living donor and deceased donor to 64%. So this poor long-term outcome has largely been attributed to chronic antibody-mediated allograft rejection. And why is this again the problem? It's because that if you look at this late graft loss, this is mainly due to non-adherence to medications, especially amongst our adolescents. So my talk this morning will then therefore focus on how do we classify transplant rejection, how do we diagnose transplant rejection, and how do we treat transplant rejection. So firstly, how do we classify transplant rejection? And for all transplanters, the age-old classification of hyperacute that occurs within minutes to hours, accelerated rejection that occurs in the first week, and acute cellular or acute antibody-mediated rejection that then occurs in the next few weeks, and chronic rejection which takes months to years to occur. And this can be both humoral or cellular. Humoral with the antibody-mediated rejection, and cellular primarily T-cell mediated. And as we know now, in the allo recognition of the transplant kidney, that there are HLA antigens as well as non-HLA antigens that stimulate not only the T cells and the B cells, but also NK cells and monocytes. And this then goes on to cause the graft injury through either antibody-mediated pathways or cell-mediated pathways. Now, the antibody-mediated rejection shows a microvascular inflammation following B cell activation, plasma cell differentiation, and production of antibodies targeting the donor endothelium. So first of all, I just want to say a few words on HLA donor-specific antibody-mediated rejection. You can see here from this slide that the presence of de novo, that means newly formed donor-specific antibodies, is associated with poorer allograft outcomes as shown by this red line. And pre-sensitized individuals have a robust, long-lived plasma cell constitutively secreting anti-HLA antibodies with a rapid and amnestic antibody response producing DSAs. So even though if you do a pre-transplant assessment for donor-specific antibodies and say it's negative, we don't know whether they're actually B cells that have this amnestic antibody response that will rapidly come about once you put in the allograft. And circulating recipient immune cells, NK cells, monocytes, macrophages, bind the HLA DSA, engaging with the donor HLA molecules, and this results in cellular activation, cytokine release, and activation of the classic complement pathway, leading to allograft rejection. Now, how about the non-HLA donor-specific antibody-mediated rejection? As you can see here, that there are also non-HLA donor-specific antibodies that may interact with non-HLA antigens on the donor endothelium. And these can be against donor-specific minor histocompatibility antigens like the MHC class 1 related CHADE or MICA. And they can also be against certain cell epitopes like the angiotensin 2 type 1 receptor and so on. So how do we diagnose transplant rejection? I'll just start with this clinical case here. 9-year-old boy with genetic FSGS, and he received a deceased donor en bloc kidney transplant with 7 HLA mismatches. Induction consisted of ATG, prednisolone, mycophenolate, and tacrolimus, and he also received IVIG and rituximab due to the presence of pre-transplant HLA donor-specific antibodies with an MFI of 6,972. His creatinine reached a baseline of 45 micromoles per liter on post-operative day 6. So everything seems good. Until 1 year post-transplant, he presented with fluid overload, hypertension, and rising creatinine to 108 micromoles per liter. And on questioning, he had missed some of his tacrolimus doses for 1 month. So the clinical features of acute transplant rejection include an acute rise in serum creatinine, hypertension, decreased urine output, pyuria, new or worsening proteinuria, fever, and graft pain, which is uncommon with the modern immunosuppressive regimens unless the immunosuppression has been missed or completely discontinued. So when we evaluate for the possibility of transplant rejection, we look for certain risk factors. How likely is this to be a rejection? So a history of allosensitizing events in this patient is very important. Was this the first transplant or second transplant? Were there many blood transfusions? In adults, they looked at the pregnancy, number of pregnancies the mother has, a reduction of immunosuppression, where the patient may be non-adherent or the physician may be tapering doses of the immunosuppression, donor-recipient HLA typing, and to see whether it's a high-resolution typing or low-resolution that was done, and of course screening for the HLA donor-specific antibodies, and deciding whether this happened pre-transplant or is a new onset antibodies. So when we approach this patient with allograft dysfunction, rejection is not the only differential diagnosis. We have to think about other possibilities like calcineurin inhibitor toxicity, BK virus-associated nephropathy. Is there a recurrent or de novo glomerulopathy? Is there obstructive uropathy? Is there recurrent pyelonephritis, especially in children with a previous history of Charcot? Or is there transplant renal artery stenosis? So when we investigate, we do things like the drug levels of tacrolimus or cyclosporin, plasma BK virus DNA. We look at the kidney ultrasound, the Doppler, including the Doppler, to see whether there's any possibility of obstruction. And we may need other imaging studies like a MAC3 renogram. So for example, the kidney ultrasound findings suggestive of acute rejection as shown here are graft enlargement, obscured corticomedullary differentiation, decreased echogenicity of the renal sinus, thickened urothelium, prominent hypoechoic medullary pyramids, increased or decreased cortical echogenicity, and on the Doppler, we look at whether there's increased recitative index of more than 0.9. Now, if you do a MAC3 renogram, which is suggestive of acute rejection, you will see decreased perfusion, delayed transplant visualization, poor parenchymal uptake, high background activity because of decreased clearance. Now, kidney allograft biopsy is actually the gold standard for diagnosing acute rejection and may accurately differentiate between antibody-mediated rejection and T-cell-mediated rejection. So this is the BANF criteria, the latest revision in 2022, which classifies the type of rejection into either non-specific changes, whether it's antibody-mediated rejection with microvascular inflammation or injury, whether it's borderline for acute T-cell-mediated rejection, or is there florid T-cell-mediated rejection, and finally interstitial fibrosis and tubular atrophy. So an example of this is shown here in the acute T-cell-mediated rejection. You see a lot of tubulitis going on and infiltration with the mononuclear cells. In the chronic active T-cell-mediated rejection, you see an increase in the interstitial fibrosis as well. Now, how about antibody-mediated rejection? Again, the BANF criteria outlines the histological evidence for acute tissue injury, including microvascular inflammation, intimal or transmural arteritis, acute thrombotic microangiopathy, and acute tubular injury. Whereas in chronic active antibody-mediated rejection, you might get transplant glomerulopathy, severe peritubular capillary basement membrane multilayering on electron microscopy, and arterial intimal fibrosis of new onset. So this is just an example for the acute ABMR showing glomerulitis and peritubular capillaritis. And in the chronic one, you see transplant glomerulopathy with capillary wall double contours. But in addition to the histological criteria for antibody-mediated rejection, we need to look for evidence of current or recent antibody interaction with vascular endothelium. So here, immunofluorescence is very important when we look for linear C4D staining in the peritubular capillaries, and there should be at least moderate microvascular inflammation. In addition, in specialized laboratories where you can look at gene transcripts and increase expression in biopsy tissue, may also be strongly associated with antibody-mediated rejection. And thirdly, there should also be some serological evidence of donor-specific antibodies 2 HLA, or other antigens. And all 3 criteria must be met for diagnosis of ABMR. So what happened to our clinical case? Our patient was noted to have mild proteinuria with moderate titers of anti-HLA DSA with MFIs ranging to 2,510. The renal biopsy of the inferiorly sited kidney showed focal mild tubulitis with mild interstitial inflammation and intimal arteritis. C4D was negative, and features were suggestive of both acute T-cell mediated rejection with possibility of antibody mediated rejection as well. So when we are monitoring for de novo anti-HLA and non-HLA DSAs, these actually occur usually following immunosuppression reduction. So that history is very important. It's either physician-directed or the patient himself just didn't take some of his medication. And of course, these antibodies also occur following rejection episodes. So this is an example of how we classify the intensity of the fluorescence. For strong binding, the MFI is above 5,000. For moderate binding, between 1,500 to 5,000. So generally, we would say that positive is above 1,500. And in the presence of graft dysfunction, detection of significant levels of anti-HLA DSA is highly predictive of antibody-mediated rejection. Now, there are also currently newer techniques, molecular techniques for detection of endothelial cell dysfunction, and these are being developed to identify rejection, and they may include transcriptomic, epigenetic, proteomic, metabolomic, biomarkers, and even donor-derived cell-free DNA. So this is becoming more and more used by many clinicians to look at the cell-free donor-specific DNA, and you see that anything less than 0.5%, as shown by this brown area here, supports the absence of active rejection, as the number of patients who have DSAs here are very low. Whereas when your cell-free DNA goes up, then the numbers who have DSA goes up as well. So how do we treat transplant rejection? So again, coming back to our patient, following the diagnosis of acute T-cell mediated rejection, he was treated with pulse methylprednisolone with a decrease of creatinine to a baseline of 49 micromoles per liter. He was also given a course of IVIG and rituximab in view of the positive DSA. Now, 2 years later, he was noted to have increase in proteinuria again, with his creatinine remaining at baseline of 42 micromoles per liter. His tacrolimus levels were fluctuating, suggesting medication non-adherence. And renal biopsy showed acute antibody-mediated rejection with glomerulitis, peritubular capillaritis, intimal arteritis, but no tubulitis. So he was subsequently treated with pulse methylprednisolone, IVIG, and rituximab. So when we look at the treatment for acute T-cell mediated rejection, the current standard of care is to give IV methylprednisolone plus or minus anti-thymocyte globulin. So this is a first-line option usually for T-cell mediated rejection with a BAMF grade, more than grade 2B criteria, or for first episode of rejection that is unresponsive to pulse steroid. So normally we give it a week. If there seems to be a poor response, then we would consider whether to give anti-thymocyte globulin. And it's also considered in the patients with BAMF grade more than 1B with severe allograft dysfunction, especially in the first year post-transplant. And following this, we need to intensify the maintenance immunosuppression as well. Now, what is the effectiveness of this T-cell mediated rejection therapy? So in this systematic review and meta-analysis, which had 10 adult and 2 pediatric studies, and of which the maintenance immunosuppression was tacrolimus and mycophenolate. So the outcomes it looked at was persistent T-cell mediated rejection and development of antibody-mediated rejection, graft loss, and mortality. So you can see that these studies use, in general, IV methylprednisolone plus or minus some ATG for the steroid-resistant ones. So what did they find? The pooled proportion of persistent BAMF borderline was 0.39 after treatment of an index borderline rejection, and was a higher proportion of persistent rejection in pediatric patients relative to adult kidney transplant patients. And the pooled proportion of persistent more than BAMF borderline after an untreated subclinical BAMF borderline rejection event was 0.61. So treating T-cell rejections is not that easy, and honestly, a lot of our outcomes may not be as good as we have hoped for, especially in the pediatric patients. Now, the pooled proportion of antibody-mediated rejection after treatment of the BAMF borderline rejection was 0.02. So this is some evidence that suggests that maybe for the borderline rejection, we should also give them pulse methylprednisolone. Now, how about active antibody-mediated rejection? Now, plasma exchange and IVIG is currently touted as a standard of care in active antibody-mediated rejection. And what does plasma exchange do? It removes circulating donor-specific antibodies, and the IVIG inhibits B-cell responses through mechanisms of binding the Fc fragment of the IgG2B receptor through its Fc portion, or induction of apoptosis of the B cells, or a scavenger of activated complement. So again, looking at the systematic review and meta-analysis of the treatment of antibody-mediated rejection, these are 21 studies, including 10 RCTs in adult patients primarily. Unfortunately, the evidence quality was low for the majority of the treatment strategies. And you can see here, the ones in blue are the randomized control studies here. That actually, when you look at the results, the pooled analysis for randomized control studies for antibody removal showed no significant difference for graft survival, whether you use plasmapheresis or not. And the retrospective non-RCT with historical controls favored plasmapheresis plus IVIG in the treatment of chronic active antibody-mediated rejection. Now, how about targeting the B cells with either an anti-CD20 antibody resulting in B cell depletion, or using an antibody like bortezomib, which is a potassium inhibitor that directly targets antibody-producing plasma cells? You can see here that in this systematic review, rituximab appeared to add little or no benefit to plasmapheresis and IVIG in randomized controlled trials as standard of care, except for some positive effects in multimodal treatment regimens. And the efficacy of bortezomib for the treatment of antibody-mediated rejection still remains unclear. There's no good evidence either way. Now, how about targeting the complement system? I think all of you are now familiar with the C5 inhibitor eculizumab. And of course, now there are also studies with the C1 esterase inhibitors as well. You can see here that there appears to be promising results in the prevention of early active antibody-mediated rejection, but no clear effect on long-term incidence of chronic antibody-mediated rejection and allograft survival. So many of us tend to use eculizumab with a very early antibody-mediated rejection immediately post-transplant, and there's very severe delayed graft function. We may want to just block the downstream complement-activated destruction going on in the kidney while we are doing our plasmapheresis and other forms of treatment. Now, how about the chronic antibody-mediated rejection? There has been some studies that look at the role of the IL-6 receptors like tocilizumab, the inhibitors, the IL-6 receptor antagonists. And you can see here that tocilizumab has been advocated for treatment of active antibody-mediated rejection in kidney transplantation. Here, there's a significant reduction in the donor-specific antibody levels, inflammation, as well as microvascular lesions with stabilization of kidney function with the use of tocilizumab. However, there's this phenomenon of a pro-inflammatory rebound with cessation of the interleukin-6 receptor inhibitor therapy due to accumulation of IL-6. If you stop the treatment, you will find that there's this sudden increase in the IL-6 action, and unfortunately, there's also modulation of the gene expression of major components of the IL-6 and IL-6 receptor axis. So therefore, this led to a development of a direct anti-IL-6 monoclonal antibody, clazakizumab, in order to tackle this problem. So again, clazakizumab in chronic active antibody-mediated rejection has been shown to also be safe and tolerable, and there is appears to be some effect on donor-specific antibodies as well as a morphological antibody-mediated rejection lesions and the molecular gene expression patterns as well. So this is one of the promising therapies that seems to be appearing for the treatment of chronic active antibody-mediated rejection. So what happened to our clinical case here? Following his last treatment for acute ABMR with IV metaprednisolone, IVIG, and rituximab, he continued to have proteinuria with donor-derived cell-free DNA that was positive of 1.4%. We therefore started him on monthly IV tocilizumab. However, he continued to have episodes of non-adherence to immunosuppressive medications related to psychosocial stresses. All this while his serum creatinine remained normal at 40 to 50. So why are these adolescents, my patient has grown up a bit more, he's now an adolescent, and why are they at highest risk of non-adherence resulting in chronic ABMR? at this age, you see, tasks related to transplant care should shift from the parents to the young recipient. And unfortunately, these adolescent recipients are also negotiating all the usual challenges of emerging adulthood, from transition from school to work, romantic relationships, achieving independence from parents. So adolescence is the period where the teen seeks out new experiences, has propensity to take risks as they feel they're invulnerable and they fail to restrain inappropriate responses. So therefore, non-adherence to medications become either intentional or actually many of them tell you that they are taking their medicines is non-intentional, they just forget. So what is the solution for this? So here we are looking at the blocking the co-stimulatory molecules with monoclonal antibodies at belatacept, which blocks the CD28, CD80 pathway. And you can see here that in this study, even though belatacept group was associated with significant increase in biopsy-proven acute T-cell rejection and worse 12-month allograft survival compared to tacrolimus, however, at least we can now supervise these patients to make sure that they are given a monthly immunosuppression while we reduce their tacrolimus to a daily dose, a mycophenolate to a daily dose, so that we are sure that they're at least taking one dose a day, because they tend to miss the second dose. And we also added tocilizumab to the monthly belatacept-based protocol to treat chronic ABMR. So this is so I would like to just end off by showing you the recommended treatment for the antibody-mediated rejection after kidney transplant from the Transplant Society Working Group. And you can see here that for the T-cell related rejection, pulse metaprednisone plus minus ATG is steroid resistant, but for active antibody-mediated rejection with pre-existing DSAs, plasmapheresis with IVIG plus steroids as standard of care, and rituximab as possible adjunctive therapy. And active ABMR with de novo DSA, we need to optimize the baseline immunosuppression, manage non-adherence, as well as plasmapheresis, IVIG, and or rituximab as adjunct. For those with chronic ABMR with pre-existing or de novo DSA, again, we need to optimize the baseline immunosuppression and maybe use IVIG as adjunct. But very importantly, there's the optimization of the immunosuppression, keeping the prednisolone at least 5 milligrams daily and the trough tacrolimus of more than 5. And I would like to end here by saying that it's challenging to manage the adolescents with a transplant. When they are young, the parents are probably the responsible adults, and therefore we have a better time. But once the child grows up, this is the biggest challenge to all the pediatric transplant team. Thank you very much.
About this condition, but there are also other patients. Unlike some of my fellow countrymen, I've got nothing to disclose. Recurrent disease, well, I think for me personally, I became aware of it with this publication, which came from my Australian colleagues. So I'll just introduce the ANZ data registry. We've heard about it a bit already. So in Australia and New Zealand, any patient, pediatric or adult, who has renal replacement therapy long-term, either transplant or dialysis, enters this registry. And as you know, many similar registries around the world, and a lot of our data comes from those registries, but there are some limitations, and it's relevant to this lecture. But this paper came out 2002, and using ANZ data looked at the risk of transplant loss from recurrent disease. And it showed that it was significant for some diseases. And the diseases here now, so this is one of the limitations of registries. Sometimes historically the labeling is not ideal, but just taking you through it. So IgA nephropathy is in there, and we'll talk about that. That's fairly faint. Membranous glomerular nephropathy, FSGS in blue, and what was labelled then as mesangiocapillary type 1, which now is going to sort of encompass things like C3 glomerulonephritis. And you can see there's different patterns for different diseases over time of recurrence of disease and loss of the transplant. Further analysis from this registry, published in 2017, looked at it a slightly different way, looked at both specifically at recurrence of disease, not just loss of transplant. Now, again, limitations here. This recurrence is usually based on a biopsy. So there's probably subclinical recurrence that we don't detect, and people's indications for biopsying them may be different. So if you're doing protocol biopsies in your centre, you may detect recurrence, but it's not clinically significant. But regardless, just let's look at this because it tells us quite a bit actually. So this is the probability of recurrence over time in years, again with a similar group of diseases. The colours aren't turning out. So, down the bottom, sorry. Blue is FSGS. Now, the interesting thing about FSGS, you can see a very rapid increase in recurrent episodes, and then sort of over time, a very gradual uptick, as opposed to IgA nephropathy, where there's this almost stable gradient over time. So, increasing people being diagnosed with IgA. Membranoproliferative showed a similar pattern to FSGS, but higher rates, as we saw in the previous slide. And membranous also, which not so much earlier on, but perhaps as immunosuppression was reduced over time, there was increased rates of membranous recurrence. So it does tell us a bit about these individual diseases. So I'm going to primarily look at, for the rest of the talk, at FSGS and IgA. So this is a study specifically looking at this in adults, the recurrence of IgA nephropathy, and it showed similar pattern to the previous slide, that in adults with IgA who've received a transplant, over time there's gradual increase in numbers that have recurrent disease. And so you can see over 15 years gets to about 20%. But recurrent disease, again, is usually histopathological evidence of recurrence. So they may not have heavy proteinuria or hematuria, but if they've had a biopsy, it shows that there's mesangial proliferation and IgA deposition. But it still is significant because it does contribute to graft loss in that population. Just in terms of what I was talking about this morning, the Hinoch-Schonlein group, the IgA vasculitis, smaller numbers that get transplanted, and some of our children do end up with the transplant. It's probably similar to IgA, and because it's not less frequent, the data is, we don't have as much data, but this study, which was from France, they did protocol biopsies, and they looked at the actual recurrence of this group of patients, and they saw by 2 years, 60% of them had evidence of IgA deposition in their transplanted kidney. And that's what we're just seeing here. This is taken from their paper. A normal glomerulus at 3 months, at 12 months, you've already got some mesangial proliferation and IgA immunofluorescence. While 3 years later, this patient was already getting some sclerosis from IgA. But overall, if you just compare patients who get a transplant for IgA vasculitis versus other patients, they do similarly well, but it does contribute to graft loss. And just before I move on to FSGS, thinking about IgA, is there anything we can do differently? There isn't a lot of evidence for what can be done differently. Probably if you withdraw steroids, they're more at risk of recurrence and significant recurrence. Now, FSGS we know has high rates of recurrence, and this goes back to our lecture this morning from Prof Chanel about the elusive circulating factor. We don't know why patients get FSGS on the whole, or steroid-resistant nephrotic syndrome. There's a lot of evidence that there's something circulating in their plasma that contributes to it, and I'll talk more about that. But again, if we look at some registries, the rates in children vary widely. Recurrence, 36% in our registry, less in North America, higher in Italy. Meta-analysis came up with around almost 40% overall of children will have recurrence of their FSGS. But if you just see, again, the registries were just reported as FSGS and won't always identify if it's genetic cause of FSGS or immunological. This analysis, they removed those that were identified as genetic, and they saw rates in the other group, the idiopathic, much higher. The other interesting thing is that we know that some patients with FSGS, historically, you'll see the first response, their first presentation with nephrotic syndrome, they respond to steroids or get a partial response, but then they become steroid resistant. For some reason, that group seems to be at higher risk of recurrence. Now, this is not a registry study. This is a North American study just recently published, and they used electronic medical records from the collaborating centres. So it probably gives us a bit more understanding of it. So there's 165 children who received a transplant for FSGS, and again, the recurrence of 40%. And but important information, again, we saw in those initial slides, you see this very rapid recurrence. And here it's clear that of these, the median time to recurrence was 1 day. So these kids are getting recurrence of their FSGS very early. Hence, we think the suggestion of there's something circulating. You put a new kidney in, their plasma causes nephrotic syndrome. And when I say recurrence of FSGS, if we biopsy them now, they don't have FSGS. They have nephrotic syndrome. So they'll have effacement of foot processes, but they won't yet have sclerosis. In this group, again, if they are the lower serum albumin at the time of transplant, but also some genetic risks as well. So a consensus statement, and we can see that Prof Yap was one of the authors on this from a few years ago from a meeting which involved both paediatricians and adult nephrologists about recurrent FSGS. So I guess the first thing is how we diagnose it, and it is a clinical diagnosis really. It's nephrotic syndrome, and well, nephrotic range proteinuria, sorry. They very quickly have heavy proteinuria after transplant. And as I said, if they have a biopsy, it'll usually show foot process effacement. And so because of this high risk, any child that doesn't have genetic FSGS, but has steroid-resistant nephrotic syndrome and getting a transplant, we need to monitor closely. What can we do though if we detect it? So again, as in all this area, the evidence is limited, but the mainstay of treatment, because it's a plasma factor, is plasmapheresis, plasma exchange. And the suggested regimen, as you see from this consensus paper, was 3 days and then three times a week, aiming to get protein down. And the good news is that many of these children respond. So you get a good response, and it doesn't always recur. So it's definitely worth treating. There's some evidence that rituximab in reducing antibody production, whatever the effect on the CD19 cells, does have some benefit. And so sort of would be the second line therapy. Now, of course, these kids are already immunosuppressed, so we're not also adding immunosuppression, but maintaining good immunosuppression from their anti-rejection drugs. In the past, a lot of the time we thought, well, if there's a circulating factor, let's remove it before we give the transplant, and that'll help prevent it. But there is no evidence that doing prophylactic plasmapheresis actually reduces the risk of recurrence, or prophylactic rituximab for that. And overall, as I said, the response is quite reasonable. Now, this is just from that consensus paper where they looked at, did a systematic meta-analysis of recent papers. Now, again, because of the evidence isn't ideal, these aren't usually trials, these are retrospective case reports. So the treatment in these was quite different. But overall, the response rate was around 60%, children and adults, in terms of remission from the nephrosis. The ones that most of them involved plasma exchange. This one that didn't quite as well. This was mainly angiotensin receptor blockade. So some of them also included rituximab and other treatments. But basically, plasmapheresis in this setting, you'd hope for at least 60% chance that you'll get into remission. But often you don't. And, well, not often, but sometimes kids, just like pre-transplant, we can go through a lot of immunosuppression to treat these children and try different things. So try plasmapheresis, then maybe try rituximab, then maybe try changing some of the other immunosuppression. This is case report that we had published, which shows ACTH. And again, we heard about ACTH this morning being useful sometimes in steroid-resistant nephrotic syndrome. So out of desperation, we tried it in this young girl who had a transplant because of FSGS, got recurrence. Despite rituximab, despite plasmapheresis, she continued to have nephrotic range proteinuria post-transplant. Her graft function was still okay. And then after about 6 months, we gave her ACTH subcutaneously. And that's when it was introduced here. And you can see the serum albumin came up pretty quickly and the proteinuria responded. And that was, I've got to say, a bit surprised, but very pleasantly surprised that it worked. We stopped it and then then it relapsed. And then she went back on it for a period of time. And she did get side effects of sort of like Cushing or side effects. So there are different things to try and they may work differently for different patients. What is the elusive circulating factor? So we don't really know, but and many things have come up, but the most recent one now is nephrin autoantibodies. And the evidence is reasonable that they're involved in some nephrotic syndromes, both primary and recurrence. But we still don't have a final decision about it. But this is all very recent data, more or less. So since over the last few years, now this is one of the first important papers that did show in not transplant, but just in minimal change disease, that detected a significant number of children and then subsequently adults with idiopathic nephrotic syndrome who had a circulating anti-nephrin antibody. Now, an interesting corollary of this, we know that patients who have genetic congenital nephrotic syndrome due to nephrin mutations, a very small number of those children who get transplanted will develop a nephrotic syndrome post-transplant. And the thinking has been that these are patients because they have no nephrin or no normal nephrin production. When you give them a new kidney, they get an antibody to the nephrin. And so that's very infrequent. But this now we're seeing this nephrin antibodies in more patients. Just to explain a little bit more about what they are. So they're an IgG antibody, they're circulating, and they're also detectable on biopsy. And it by an antibody against nephrin, and it alters nephrin phosphorylation, and that then in turn alters signaling within the podocyte, and so changes the structure and the function of the podocyte. So it makes sense that that would cause nephrotic syndrome. So this is just recently published New England Journal earlier this year, where they looked at both children and adults. So this was, again, not in the transplant group, and so these were patients that had were already in registries and had serum collected previously. And so now they've gone back and they've looked at that serum to see if they had nephrin antibodies. And in the group, there was 182 children with idiopathic nephrotic syndrome, both minimal change and FSGS. And they found that 52% had detectable antibodies when blood was collected. Is this big enough to see? This is the adult group, this is the pediatric group. And in the pediatric group, idiopathic nephrotic syndrome, close to 50%. But if they were nephrotic at the time the blood was collected was higher, and if they were nephrotic at the time without being on immunosuppression, they were much more likely to have a nephrin antibody, and it was associated with higher levels of proteinuria, lower levels of albumin, and also cholesterol. So it, based on that study, it did look like it was involved in idiopathic nephrotic syndrome. And then this group used mice and did just an immunization of the mice. They gave them nephrin, subcut nephrin, and these mice got an antibody to the nephrin, and then the mice developed a minimal change nephrosis. So there's a lot of things happening. And so what's the relevance to post-transplant? Well, it does seem there's been a few papers coming out that are saying that patients who have higher levels of nephrin at transplant are more likely to relapse. And as you can see in this study with relatively small number of patients, but is showing that that on biopsy post-transplant with relapse, they're detecting the nephrin antibodies. And so suggesting that at least in some of our patients, maybe nephrin antibodies are the circulating factor. Doesn't change at the moment how we treat it. It would still be plasmapheresis. And finally, that's my last slide, so I've got a bit of time now, is I just wanted to talk about one other disease that we see more so in children is C3 glomerulonephropathy. Of course, it's rare. It was that group that in those earlier slides was previously known as mesangial or membranoproliferative, and often membranoproliferative. It can be dense deposit disease. It can be just a C3 glomerulonephropathy. But we know this group has high rates of recurrence. We know that treating them pre-transplant is difficult. Different centres may try eculizumab and other complement inhibitory factors and get some response, but often these kids, as you know, will progress to kidney failure. If they get a transplant, there's a high risk of recurrence and a high risk of kidney failure from the recurrence. So thank you. That's
Can I just ask for a show of hands? How many of you look after kidney transplant patients? And how many of them are children? Peds. Okay. I think this discussion on transition would apply to any child with a chronic kidney disease. So, I'm not going to talk too much about the immense amount of research that has gone into transition and healthcare transition, but these are essentially the four of many people who are working in this area in different parts of mostly the Western world. So I would advise you, if you were really looking into the literature about it, these would be people, especially Dr. Maria Ferris, who has really done amazing work on healthcare transition for children with kidney diseases. I'll focus a little bit more on the practical aspect. So we'll start with a case. This is a 16-year-old boy with a history of posterior urethral valves, and he underwent a living-related kidney transplant 1 year ago, so he was 15. 3 years before his transplant, that must have been about 12, he had required bladder augmentation and was initiated on clean intermittent catheterization via a metrophenol. So the donor was his mother. Initially, when he was started on CIC, she would do it for the boy because he was unwilling to do it himself. And then gradually, by the time he was worked up for transplant, he agreed to do the CIC himself. So post-transplant, the boy had 3 UTIs. So he had recurrent UTIs, but no rejection episodes. And his graft function currently is stable with a creatinine of 0.8. So he's finished his 10th grade, and I don't know how it is here, maybe similar, but in India, after the 10th, many children get ready for junior college. So his mother administers his medication and brings him to his appointments and fills his prescriptions. So here's the question. Should this child be transferred to adult nephrology? He's going to junior college now. He goes there on his own, takes his own transport. If yes, is he ready to manage his own health from what you read about him? And if no, how should we get him ready to manage his own health? So that's what we'll talk about a little bit today. So what is healthcare transition? So as you can see, there's much more to transition than just transferring a patient from pediatric care to adult care. So transition is an anticipated, coordinated process of movement from child-centered to adult-oriented healthcare. That's the official definition. Whereas transfer is just an event. It's just goodbye from pediatric services and moving to adult-focused services. So for those of you who are familiar with adolescents, and we all have adolescent patients, and I have 2 adolescents at home, we know that their brain works differently in that it's growing and developing very rapidly, and there are many conflicting interests, pressures that they face. So adolescence is defined between 10 to 19 years of age. It's a period between childhood and adulthood. It's associated with rapid physical, cognitive, and psychosocial growth. They're becoming smart people. It's also associated with some reward seeking, because that's what the part of their brain that develops sooner than the more controlled thinking part of their brain. They're greatly influenced by their peers. And the self-awareness, self-control, and planning takes a little bit longer for them to develop those aspects of their brain function. So as a result, they're a bunch of risk-taking people who really don't care too much about the consequences of their action, because their brain is not developmentally ready to do so. So adolescents are between 10 to 19. Young adults are, by definition, 19 to 24 years of age. So both adults and pediatric specialists will look after this group of patients. So this is a, well-known slide showing that while mortality rates of pediatric kidney transplant recipients are reducing over time, the common causes of death are cardiovascular disease, infection, and cancer. But the most significant risk factor for death in this study was a failed transplant. And this is important because, as we'll see in the next slide, adolescence is the period where the risk for a failed transplant is the highest. So losing a transplant has very severe implications. These patients had a 3-fold higher mortality risk. So in this paper, they looked at the risk of graft failure at different ages of the patient. And what they found was that the risk of graft failure rises during the adolescent age. You can see that it's peaking between adolescents and young adult age, 17 to 24 years. And this is irrespective of the patient's age at which they were transplanted. So it's the age that seems to be the risk factor of the patient and not the time that they were transplanted. It also happens to coincide with the age of transition. So what's going wrong? It could be all the aspects of adolescence that we discussed, which is fine for any adolescent who doesn't have chronic health issues, but can be extremely serious and detrimental to their health if these adolescent issues play into a child who has a chronic illness, requires multiple medications, and has a lot of health issues. So this is a period where non-adherence increases. It goes from the parent who has been managing the child's health to the adolescent taking over. And if they're not ready to take over, then medication adherence results. And as you heard from Professor Yap, the risk of rejection significantly increases when there is non-adherence in transplant recipients. So patients, especially in our culture, maybe it is similar here, they lack self-management skills. They are still treated as children, even though they are older adolescents, and nobody really gives them this push to be more independent. However, there's a big difference between pediatric and adult services in what they expect of the patient to be able to do. And so if there is no proper transition and just a transfer of service, the risk of graft loss is going to be significantly high. So what is transition? It's a purposeful planned movement of adolescents and young adults with chronic physical and health conditions from child-centered to adult-oriented healthcare systems. I think this bears repeating because really the words are important and the planning will fall to us in pediatrics. So this is a statement of need from the American Society of Transplantation. Transplantation is the treatment for kidney failure, no doubt about it. And pediatric recipients are becoming long-term survivors, so the adults will have to deal with all these patients who are going to be entering into their care. And adolescents and young adults are really most vulnerable during this transfer from pediatric care to adult care. And so the goal is to transfer them to adult care, but through a pathway called the transition pathway. So this is an ideal timeline of transition. As you can see, it begins very early. It begins at 12 and goes all the way up to past 18, which is where the pediatricians, as in most parts of the world, will hand over the child to adult care, transition continues when the patient moves into adult-oriented programs. So the timeline begins with transition planning, then preparation, and then integration. So what are the additional challenges of an adolescent with a kidney transplant? Aside from the medical complexity, they take a lot of medications, they have a lot of healthcare issues. These children are often have a history of CKD for a long period, and they have a cognitive delay compared to their peers. They have a lot of psychosocial issues. They may have body image issues. They may not like taking steroids. And there's also, more importantly, a lack of preparation for transition. So this was a survey of recipients, transplant recipients, and essentially, you may not be able to read the questions, but the proportion of patients who were prepared for transition was quite low. So what are the challenges that are encountered during the transition process? And really there are challenges all around. It begins with the adolescent himself or herself. It extends to parents, the healthcare system, pediatric renal unit, and adult renal unit as well. So we'll discuss in the next few slides specific issues that each of these people face. But one note about the healthcare system. Most healthcare systems, especially in lower resource settings, they are not geared to transition patients in a smooth way. Oftentimes, pediatric nephrology and adult nephrology services are not available in the same center. There's no electronic health record that will transfer from one institution to the next. And there's really no way of supporting professionals to visit one hospital and the other. So if we look at this ideal model of transition, you can see that the adolescent, starting from age 15 until they're young adults, will go through this long period of transition. And in the beginning, in the orange, a lot will be done by the pediatric team. But at the same time, beginning in their mid-adolescence, there's an involvement of the adult nephrology team. I have to say that in my center, and we have both teams in the same hospital, that just doesn't happen. But it would be ideal. And in many centers, it does. So this period where there's an overlap of the pediatric nephrology services and the adult services would ideally be called a transition clinic, where everything is focused on the adolescent and would include many different team members. So the challenges from the adolescent's perspective is that they're under a lot of pressure. It's not that they don't care. Especially in low resource settings, transplant is a one-time chance. They are not likely to get a second transplant if their first transplant fails. So it's high stakes. The focus of the pediatric nephrologist, who also knows it's high stakes, is on giving information to the caregivers all this time. The caregivers who feel the same pressure would like to manage their child's care as much as possible. The medical team has not educated the patient himself on medical diagnosis and prognosis, the implications of non-adherence, and how the adult nephrology clinics work. And so, because of all these challenges, the timing of transition, the adolescent is really not fully prepared. From the parent perspective, they have been the responsible primary caregiver for all these years, and it's difficult then to consider that their child could now take over. The pediatric transplant team is almost their family. They're very comfortable with the team, and you know how pediatricians we all are. We like to handhold and cocoon them in this feeling of comfort. They're unsure how much to let their child go. The adult nephrology team are all strangers to the caregivers, and adult nephrology environment may be intimidating. There's many more patients, it can be crowded, and it's not that it's better or worse, it's just different. If we look at the nephrologist's perspective, from the pediatric nephrologist's perspective, transition can be time consuming. You can see it goes on for years, it's resource intensive. When there are 10 other patients lined up to be seen, how much time do we really have to educate these patients? How do you assess transition readiness? In that patient with PUV, is he ready? Should we use age cutoffs, or should it be based on the knowledge of the patient themselves? And oftentimes in smaller centers, there's no adult nephrology unit on site, and expecting them to visit a ped nephro center would be probably not going to happen. From the adult nephrologist perspective, this is a new patient. They don't know who they are. They've had limited training in managing pediatric kidney diseases like valve, cystinosis, diseases that children never survived into adulthood for. And they're expecting a self-managing patient, and hand-holding is not their standard practice. So how do we assess if a patient is transition ready? One way to do it is to use this mnemonic called RISE. Does the adolescent understand what their disease is? Not just name it, but understand it. Do they understand how it's going to affect their health in the future, and what their prognosis and survival expectations are? Adolescents want to know. We sometimes don't want to tell them. Do they have insight? Do they understand that what their weaknesses and strengths are when it comes to adherence? Are they self-reliant? Do they manage their own treatments and appointments? And we need to establish, before transferring them to the adult care, we need to establish good basics, healthy lifestyle choices, the need for absolute lifelong adherence to immunosuppressant medication, and of course, to help them gain psychosocial skills and achieve their life goals, which all sounds like a lot that we have to do. So back to our case, as if you remember, should we transfer him to adult care? Is he ready? No to both, because we really don't know. So what should we do to prepare adolescents for transition? We begin with education that is age appropriate. They need knowledge about their disease. We need to enhance their health literacy, right? Reading their own reports, asking questions, understanding what the reports mean, not just explaining it to the parent. Discussing true risks and complications that the child has in an age-appropriate way, which requires us all to be good communicators. We need to know how to talk to adolescents, which is not the same way as talking to adults. What the consequences of non-adherence are need to be reiterated. Teenage brains really don't remember what consequences might be. And discuss lifestyle choices with them for the future. What is healthy versus non-healthy? So if you're looking for tools, this is easier than palliative care. There's a lot of easy to access tools for transition that we can all use. So this is the American Society of Transplants early transition tool. And you don't need to read this, but essentially it goes through all the aspects of education right from the age of 11 years, but in increasing levels of complexity for the adolescent brain to understand. There's also a transition readiness checklist that can be used, that can be filled by the parent and the child themselves. This is a time, middle adolescence, 14 to 16 years, where we need to begin speaking to children directly and respectfully. They're intelligent. They probably have a good understanding of what they need to do to take care of themselves. And we also need to consider speaking to these adolescents alone. In my setting, it's really not culturally acceptable to ask the parent to step out, but we could certainly take them to the examination corner, ask them a few questions, and focus really on them. So this is an action plan in the late transition years. So this is now becoming more and more detailed, and this is a plan that the adolescent has to be able to complete before they are transition ready. So that's just one example of what the role looks like, but essentially it assesses their transition readiness in the domains of transplant knowledge, medications, assessing their own adherence, risk-taking behaviors, managing their own health, and other important aspects like schoolwork, their self-esteem, their family support system, and critically important, how is their healthcare going to be paid for? Many adolescents at the age of 18 may not be able to receive their parents' benefits anymore if they're on their insurance, and may lose their financial support. And of course, reproductive health. So we know that non-adherence increases during adolescence. How can we as pediatric nephrologists work with them to improve and sustain adherence? Education. We've talked about that many times, but also a simplification. We tend to write a lot of medicines. Sometimes the timings are explained by somebody else. The patients sometimes don't know whether they're supposed to take it before food, after food. Can two medicines be taken together? Usually we just write a prescription. So creating a little workbook of sort of how the adolescent is supposed to take their medicines might simplify the process. Using technology like apps and reminders on their phone, assessing their understanding, having them repeat back to us what their understanding of their medications are, and asking if they're adherent. So this may sound, they roll their eyes at me, but every single time, every single visit, I will ask them in the last 1 week, how many medicines have they missed? And invariably there's a minor confession. They understand that they're not supposed to take it late, so they may even confess to taking it an hour late. So they need to be able to self-manage and advocate for themselves. We encourage patients to ask questions, ask their opinion on treated choices, and give them tasks to complete. They also need to balance their life in other aspects as well. So this is an example of a transition passport, which is a fancy name for a small cheat sheet that the patient can carry around in their wallet or in their bag, or have a photo of their phone of their basic medical details. There are many tools that are provided by Dr. Maria Ferris's unit, which is all about transition, which I'll share the website of. But essentially, transition readiness can be measured with an index. These are all the transition tools that she has available on her website. And what is our duty? Our duty is to fill out a good detailed transfer summary. This is an example of what all to include. We know that transition can be resource intensive. It takes a lot of people and quite a bit of cost. So in lower resource settings, this may be a bit of a struggle. On the left, you'll see a long list of people who should be part of the transition team. I don't have access to half these people. So in the figure, you basically says the core people you need: the adult nephrologist, pediatric nephrologist, the parent, the transplant coordinator, all working with the adolescent. So just a brief word that the two systematic reviews have looked at the benefit of transition programs. Yes, we all understand that it's important. We instinctively know that it is. Multiple studies have shown it. But when a systematic review has been done, because of the different transition protocols that exist and the vast diversity in practice, there is no clear-cut statistically significant benefit that has yet been able to be demonstrated because of the diversity in studies. So therefore, we need consistent transition protocols that will allow for better data for us to improve and apply those protocols to the rest, to all parts of the world. So this is our transition tool. This is a review that we wrote. This is the tool that we use in our clinic. And it just goes through, it may not be as detailed as the AST one, but this is something that we can do in, half an hour, quite well. And going back to our case, to prepare this patient for transition, we would need to educate him, begin the transition process, which we have not yet done. We need to assess his readiness. Most importantly, introduce him to the adult nephrology team. So what we do is we take, instead of they coming to us, we go to them. So we take the patient, family, and our social worker, and one nephrologist goes and introduces our adolescent to the adult nephrologist. And transfer only when transition ready. It's okay to follow them for another extra 6 months. It's okay to wait till they've settled down in their education transition, and then only transition them.